Okay, I'd like to discuss the vexed problem of chronic pelvic pain, and I'm going to be looking at chronic pelvic pain from a myofascial component, or from a myofascial point of view, because interestingly, it's now increasingly being recognized that chronic pelvic pain is partially and sometimes completely caused by myofascial dysfunction within the pelvis. The medical profession up till now has focused incredibly exclusively on the pelvic organs and have missed this huge component of this huge cause of chronic pelvic pain. Chronic pelvic pain, massive problem in the world. Incidence would be 12 to 15% of all chronic pain is pelvic pain. And in women, it's much more common than men. Women have more pelvic organs and have more things that can go wrong and can actually cause pelvic pain through those organs. And so men, really there's only one major structure in the pelvis which causes pain, and that's the prostate gland. Obviously, your male and female share bladder, rectum, and then men have a prostate and women have vagina, and then we all share a urethra. So these are the different structures that can have things go wrong with them, and there's a whole massive list. But in the big number of people who have chronic pelvic pain, when you look for actually organic problems, it makes up probably 70%, which leaves you 30% of chronic pelvic pain, which is unexplained, unless you understand that a significant proportion of those and a significant proportion of people who have obvious other organic pathology in their uterus, ovaries, rectum, urethra, prostate, and so on, all these structures will have myofascial pain as a component of that. So the muscles of the pelvis, well, here's your pelvis, and if you look at the pelvis, it really is it has the shape of a bowl. And you have at the back the sacrum, then you have the two pelvic halves, which involve the ilium, which is the major part of the pelvis. You have the pubis in the front, and you have these are your sitting bones, the ischial bones, and those are the main elements of the pelvis. There are three joints, two sacroiliac joints, and this in the middle, which is your pubic symphysis, which is not a mobile joint but allows a certain amount of independent movement of either side of your pelvis. And the sacroiliac joints plus the pubis symphysis allows force to be transmitted through the pelvic circle. A circle is a very strong structure, but allows a certain amount of independent movement so that the force shifts in complex ways through the elements of the pelvis. Now, the muscles that are inside the pelvis, they basically they invest the inside lining of the bones. The structures that we all have, the rectum, which runs down through the back, the urethra, which runs down through the front, and in women the vagina, which runs through the middle, they pierce these muscles, and the muscles themselves are arranged in slings. So you need to see it like this, so that the muscle will start from the pubic bone. It will run around and come back to the pubic bone like that. So it will form a sling around a structure running through. And so often in the middle, where it comes round, it'll actually form a little fibrous nodule or a body, a little fibrous body. So each muscle from each side will join in and join into these little fibrous bands. And if I turn the pelvis this way, here is the coccyx, which forms the part of the base of this cup, which is now facing towards me. There's a muscle which runs from the pubis and runs down to a little body here, which is the coccygeal body. Then there's the anus. Then there is a perineal body which sits between the anus and the vagina or the urethra in a male. And there are other muscles that attach to that. So you can see a series of slings moving further back, creating this cup. The muscles are called the Levator Ani. Those are the main muscles which levator is lifter. So it's basically holding your insides up, lifts your anus up so that it doesn't fall out on the street. As you constrict your pelvic muscles, so you will constrict, depending on which sling it is, you will constrict that organ. So you can squeeze the urethra, you can squeeze the vagina, you can squeeze around the anus. And all of these pelvic slings help with continence, and they help with holding everything in. The muscles themselves are, when you look at levels in the body, there are basic, when you are a little fetus, there are layers in the body, and the layers of the deepest muscles of your back, which are the multifidi, that layer will continue on as the pelvic floor. So they have a similar nerve supply, because they're all part of the same embryologic layer in the body. A deep pelvic muscle, deep stabilizer muscles of the lumbar spine. The commonest symptom that you get from myofascial dysfunction in the pelvis is localized pain. But the pain itself is deep in the pelvis, and you will feel it, the person will describe it as somewhere deep inside the pelvis. When you find the trigger and press on it, that is actually where you're feeling the pain. It spreads slightly, but there's no huge spread, as you find with other triggers where you'll get pain going down your leg or going into your arm or coming from your shoulder or coming right up into your head from your neck. The pelvic ones tend to be localized in the pelvis. And as I said before, the chronic pelvic pain in women, the commonest difficult chronic pelvic pain is endometriosis, where it is a very significant ongoing chronic and difficult to control pain. And the commonest chronic pain in men is what's called prostatitis or prostatic related pain. And quite often in these two very, very important causes of pain, incredible disability. People describe this as the most incredibly difficult to cope with pain, deep, deep inside your pelvis. Quite often, the diagnosis of prostatitis or endometriosis turns out to be a It's a diagnosis because nothing really else can be found, and because people haven't looked for those triggers. So the way you find pelvic triggers is you have to access the inside of the pelvis. And both men and women, you can access it rectally, and in women you can access it vaginally. And the Levator Ani muscles, actually, if you so this is something that there are a group of physiotherapists, the majority are female, who have been trained to treat pelvic triggers. And you see by this, because they're recognizing increasingly that chronic pelvic pain is related to triggers, by this a lot of men get excluded because they just, oh, you've got chronic prostatitis, use these antibiotics, take these anti-inflammatories, take these painkillers. And it's not recognized that men have quite a proportion of men. It's not prostatitis, and it's actually deep triggers. Okay, so the way that it's done is that the person lies on their side. You do a rectal examination, so you put gloves on, you put ointment, slip a finger into the rectum. That far into the rectum, if you turn your finger to the side like this, you hit a rim, you can feel a ledge of muscle, which is the pelvic floor, and you're just going against the pelvic floor, and it's in a, you can feel it in a ring around, and it's the loop is around the back of the rectum. So you start about there, and as you put pressure against it, it will be uncomfortable in everybody. This is an area where, you know, nobody likes having someone poke a finger up their bottom, but apart from being it would say that's, well, yes, a bit uncomfortable, but when you hit a trigger, they almost jump off the bed. So as you push the finger in and you move it gently around, you will find a certain point where they'll say, oh my God, that's horrible. And so you're on a trigger. Then you have to turn your hand round and come round the other side and feel. So using from the rectum, you can easily feel the whole puborectalis or pubococcygeus sling. And that is, the pubococcygeus sling is the primary part of the Levator Ani muscles. There's a second sling which arises from the ischium, and it also forms a sling, and it's called the ischio-coccygeus, so it attaches in here. And to feel that, you need to go a little bit higher up. So I hope you can see that. As you put your finger in, you go up higher, and you run your finger, rather than round the little rim, you run your finger round the actual inside of the pelvis. So you're going further forward, and you can go up quite high until you almost over the sciatic notch, and you're running your finger over the muscles that invest the inside of the pelvis. The main muscle is the obturator internus that runs through here, and again, this is a muscle that can have exquisite triggers, and those triggers are felt inside the pelvis and kind of dribble down the inside of the thigh and into your buttock. And so once you find the trigger, then you use exactly the same principles that I have described before. You use ischemic pressure, so you press hard enough to cause pain, then you reduce the pressure, and all the time looking at the person talking, and you say, okay, now just relax, okay, no pain, how does that feel, is that comfortable? Okay, and then you gradually increase the pressure and get them just to focus on their breathing, gradually increase the pressure until the whole thing starts to settle. Often, because the muscles are running in this kind of direction, once the trigger has been turned off, you need to stretch it. And the way you stretch it is that you strip the muscle. So you go inside and you just go gently around the rim of the pelvis, stretching the muscle. Some experts would say you take the coccyx and mobilize it backwards, again stretching the muscles of the pelvis. All the time, this is exquisitely tender stuff, and so all the time you're just making sure, obviously, that the person is relatively happy with what you're doing. It's the kind of work where if you had a woman and you were a male, maybe you shouldn't be doing it, or if you were doing it, you would absolutely need to have a chaperone there, and you need to be very, very sensitive to the needs of the person you're treating. The fascinating thing is how effective this treatment is. That people can have had chronic pelvic pain for years, have been given diagnosis by urologists or by gynecologists, have been told that they have this or that, have had a number of laparoscopic procedures where people have gone inside and looked and maybe removed an endometriotic nodule or two, or removed a little cyst that's on the ovary, or something like this, or even had major surgery, hysterectomy, removal of ovaries, and still they've got their pain. 2 or 3 treatments and their pain is dramatically reduced. It's previously it was boggling to me, because I've always been interested in trigger points, that this was something that was not recognized. I'm very grateful, and I'm sure there are many tens of thousands of people that are very grateful that this other specialty of women physiotherapists with knowledge and experience in this area have risen up. So this is something really worth learning about, especially if it's an area where you see a lot of people who have pelvic pain. I encourage you to go into it, because it is really surprisingly effective, and as long as you have a good communication, it is relatively non-traumatic. There are none of them have really worked. There are a number of kind of little tools with curves and points on them where people can try and insert it into their own pelvis, but they're very, very difficult, and I've never had anybody who's gone that way who's treated themselves successfully. But there are these things on the market. Much more effective is somebody else, you treating somebody else, and just doing it with sensitivity, accuracy, and recognizing that you just have to sneak up on the trigger and then turn it off, stretch it, and it's amazing how much better people feel. Thank you.